Welcome to Halteres Presents, a brand agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Thayer and Mickey Urdea.
Hello and welcome to Halteres Presents. This is Rich Thayer, Managing Partner at Halteres.
And this is Mickey Urdea, Founding Partner at Halteres.
Today we are interviewing Dr. Bela Matyas, the Health Officer and Deputy Director of Solano County, California.
We're very eager to interview Bela because we've known him for quite a while. He's a very interesting person, very knowledgeable in the U.S. public health system, and has a set of, what you'll find to be very interesting opinions.
And now our interview with Bela. Hello, Bela. We're really excited to have this interview with you today. Could we start by you telling us a bit about yourself and your career in public health?
Thank you very much, Rich and Mickey. I have been in public health for about 35 years. I started my public health career at the Rhode Island Department of Health, and then from there went to the Massachusetts Department of Public Health. Between those two, I worked out in the East Coast for about 20 years, and then returned to California, where I worked with the California Department of Public Health for a little under 2 years before I became the public health officer for Solano County. And I've been the public health officer in Solano County for the past 13 or so years.
Wonderful. Public health plays a vital role in our everyday lives, yet many people are not aware of all the areas where public health departments are involved. Please tell our audience more about the role of public health departments in the United States, key public health programs, and some of the vital services provided. And historically, what are some of the major accomplishments and achievements of the U.S. public health system?
Well, let me start by saying that public health as a practice is performed by many sectors, not just government. So, when you think of public health, you think of the government health department, the CDC, the state health departments, the local health departments, and they obviously play a very critical role in public health. But environment departments play a huge role in public health as well. The private sector has a huge role in public health. The private sector is where most diagnostic tests that we rely on are produced. They are the producers of vaccines. In addition, you have the academic sector, where a tremendous amount of research into public health practices is performed. So if we think of public health, the big public health, it's performed across many sectors because it's so important to our existence for our communities to be healthy. And then there are the specific roles that tend to be assigned to public health departments. So public health is mostly focused on prevention. Our goal is to have bad things not happen. So in a perfect world, you'd have no idea we exist because we would be preventing all bad things from occurring. Obviously, we don't live in a perfect world, and we become evident from time to time. And when most people think of government public health, I think the two areas that first pop into mind are communicable disease control and public health laboratories. But public health programs typically do much more than that. We very often also provide programs to help families in their perinatal period. In other words, from pregnancy through delivery, through the first year of life of a child. So we have maternal and child health programs. We have nutrition programs, including WIC, where we help people understand what constitutes good nutrition and also help them get access to healthy food. We focus on chronic disease prevention, injury prevention. We typically will have epidemiology and data resources that allow us to do surveillance and to make sense of what we see. Many health departments also run emergency medical services programs and emergency preparedness and response programs and vital statistics. And then relatively unique to Solano County, we also operate our family health services clinics. So we provide primary care and dental care in our public health programs. And we also provide older and disabled adult services, which is a whole range of programs that focus on the needs of the elderly. So a lot of times people will say, if you look at one health department, you've seen one health department. And there is a truth to that. There is a tremendous amount of variability in what individual health departments do in a community. And it reflects the community, typically. In some communities that are relatively conservative, you may see less in the way of public health infrastructures. In what would be described as more liberal communities, you'll often see a bigger footprint for public health. But most of what we do falls into two categories: information and services and programs designed to help the community as a whole, usually focused on prevention, and services directly provided to residents of our community who are in some form of need. So, those are sort of the two sets of programs that we operate. As for major achievements in the U.S. public health system, I would say that if we go back to 1900, the three things that have most increased American lifespan have been sanitation, basically removing sewage from drinking water, vaccines, and nutrition. I would add to that a fourth pillar, which is smoking cessation. If you go back to the 1950s, over half of the American adult population smoked, and now that percentage is somewhere between 12 and 15%, depending on the community that you're in. That has resulted in a tremendous reduction in chronic disease deaths due to smoking. And then there's also the importance of surveillance. Public health, has, an achievement in public health is our ability to keep track of things.
And we still have no doubt, Bela, why you are so popular. That was a very good answer. I really like how you wove in there that public health isn't just, the government-run agencies. There's really a whole, consortium, if you will, of stakeholders involved. Wonderful answer.
And I would, and not to blow smoke up here, but I would argue that you guys are part of that. The work that Halteres does actually promotes public health.
Yeah.
It's in a specific niche, but you provide advice, consultation to entities to do public health better.
Mm-hmm.
Thank you. We try.
Thank you.
Bela, how are public health priorities established, and where does the funding come from? And how long is a funding cycle for you?
The answer to that is actually not simple. We would like to believe that public health priorities are established through evaluation of data exclusively. That we look at what's problematic in our community, and that's what we focus on. The things that cause most death and most morbidity are the things that we focus on. And there's definitely an element of truth to that. Certainly from our perspective, when we set priorities, we focus on data and try to identify the biggest risks that are potentially amenable to prevention, right? So we focus on smoking cessation. Hard, it's taken generations, but smoking was the number one cause of death in this country in the 1950s, and we have spent a lot of resources tackling it. But if we're being honest, in addition to evaluation of data as a driver for priorities, there's also political considerations. Public health departments live in a political reality. And there are many jurisdictions across the country that prohibit public health officials from pursuing certain types of programs for political reasons. A clear example of that is needle exchange programs to prevent HIV transmission among drug users. And so these are political dictates that govern the nature of the priorities for that jurisdiction. And you will see a lot of differences in priorities between a state like California and a state like Florida or Texas. And none of that's illegitimate. Keep in mind that we live in a democracy, and government public health is supposed to be responsive to the community that jurisdiction serves. So in Solano County, I have to take input from the community, including the political representatives, the electeds, because they are helping me to set the priorities that they value, that they think are important. So there's nothing wrong with the political considerations. I mean, I think the real issue here is that you don't want to become political in the programming that you do, but political considerations are obviously important. So what you end up then having is a combination of expertise, political considerations, and basically just public desire, resulting in laws and regulations and expectations. And then those in turn result in services and programs that we provide to the community. And that's why at the end of that chain of events, you'll see so much difference between one community and another in terms of the actual programs, the actual services that public health provides. And then all of that is modified by current reality. We had our priorities in place until, and we were smoothly moving along, and then 2020 happens and COVID happens, and all of a sudden all of our priorities have changed. So, priority setting is both long-term and strategic, but it's also tactical. We have to respond to things that are happening in the moment. And then in terms of where does funding come from? It's mostly government funding, federal and state resources that are gathered from various taxes and fees that are then provided to public health departments to be able to implement their programs. But there are also foundation dollars that flow. So there are private sector dollars that flow into public health. What we find is that by and large, most of the funding for public health is issue specific. And that's problematic. We get money to do X. We don't get money to do all the things we think are important. And there's very little of our total funding that is truly discretionary, that we get to program in the directions that we want. So it's frustrating to know that chronic diseases and injuries are huge contributors to preventable death in our country, but we get no funding for them. And so, what we have to do is be creative. We got a lot of money for COVID and we were able to deal with COVID, but it could only be used for COVID. But, COVID doesn't exist in isolation. So, one of the challenges is to take those funding streams and help them address all of the needs that we have in a way that's legally defensible, but also helping the community. And then in terms of funding cycle, we operate on annual budgets, but some of the funds that we receive are multi-year, and some of them are only for a few months because it's a project. So there's a range of funding cycles, but I would say that in government generally, we operate on an annual budgeting cycle.
Mhm. Yeah. When you talk about the interaction with the community, who are some of the stakeholders that you actually interact with? What does that look?
Yeah, there are actually a lot of stakeholders that are relevant to public health. We have healthcare providers, hospitals, clinics, physician groups. We have laboratories that are part of that community. We have schools, which are an extremely important part of our communities. We have community-based organizations. We have public safety, police and fire and EMS providers. And all of these are clearly important stakeholders, but the ones that we cultivate the most because they're hardest are the community-based organizations. And they vary from one community to another. We in Solano County don't have a lot of CBOs relative to our Bay Area neighbors, but we do have a really strong faith-based presence in our county. So faith-based institutions are really an important CBO for us to work with. But what we don't have are the well-funded, large community-based organizations that focus on a community specifically. You see that in a San Francisco, in an Alameda County, Contra Costa, and it's very valuable to have that because they serve as an intermediary ear for us from the population directly that we're trying to serve. So we try to supplement the relationships with these organizations through surveys, through having open access to us by anybody in the community who would like to contribute their thoughts. We periodically go through formal needs assessment processes, community needs assessments, where we have focus groups. We work with the providers and the CBOs, but we also try to engender support from people who otherwise would not participate. But the challenge is civic engagement. Civic engagement varies tremendously from one place to another. And if you've got a community with relatively little civic engagement, it's harder to get the voice of the frontline community, and you have to rely more on those intermediaries. You hope that the community-based organizations and the provider groups are representative of the needs of the community.
Yeah, we've learned that lesson the hard way up there in Africa, and undoubtedly it's the same here in America.
Well, there's an expectation that the community makes its needs apparent through intermediate organizations that represent them. That's an assumption that we make, and that's an assumption that's valid in some places, but isn't really valid in most of the country. I think the average person doesn't affiliate with CBOs, doesn't affiliate with civic engagement in a way that you can know what their needs are. So you hope that what you're doing is meeting their needs, and you rely on the fact that if you're not, that there will be people who complain enough that you can, understand where you're going wrong and try to redirect. So, I think that people throw out this notion of, well, just get everybody's input. Well, in our county, we have 450,000 people. There is no single channel. There are no dozens of channels of communication that can get input from all of them. And the vast majority would sooner ignore me than actually give me input if I asked for it. So, part of this is feedback. We provide services, we provide programs, and we have to look for evidence that that's making a positive change. And if it's not, be prepared to redirect.
So in order to have the community engage, they have to know what you do and what they can do. Do they? Do they know what public health does?
No, they don't. And I'm not really sure they have to know what we do. What we have to do is give them an opportunity to express what their needs are, and then to reflect with them on how much of that we can help with, how much of it we can't, and who they need to work with for the rest. So public health, one of our primary roles is to be a convener. We recently did a periodic community health needs assessment and learned that one of the biggest concerns people have is behavioral health issues, insufficient mental health resources and substance use resources. We don't do that in public health, but in our department, we have a behavioral health program that does do that. So what we were able to do was to bring the behavioral health program together with us to that community session to help them express their concerns in a way that we might actually, as a department, be able to help, even if it's not public health. So, yeah, you could argue that perfect knowledge would make it easier for people to give feedback. But honestly, I don't think most people have the time in the day to care. And I think it's much easier to say, hey, you're living a life in this community. What are your issues? And then let's see what we can do to help. Because we don't have to be limiting our responses to things that my department does. Like I say, we can collaborate with multiple partners to deliver a response to a concern.
Makes sense.
Bela, in talking with Kaiser, we understand that one of their biggest challenges in California is mounting outreach programs to migrant individuals who are part of the Kaiser program in the area of diabetes. Is that something where they would team up with public health, or is that purely a Kaiser directed program?
No, that's exactly correct. That they would be teaming up with public health, because public health would have the community connections with the farms and the farm worker advocates to be able to reach out to those individuals. So, for example, with COVID, we wanted to vaccinate the migrant workers, and Kaiser asked for help, and as did other healthcare providers. And we used our connections with the farm worker community to identify inroads for that. And then they provided the expertise, the actual vaccinators, the vaccine, et cetera. But we were able to make the connections in such a way that the farm working community was actually comfortable showing up for that service to be delivered.
Brilliant.
Yeah. You've already talked a bit about the impact of COVID-19 pandemic on public health, but during that period, public health departments came under significant pressure to continue to offer other vital services while at the same time supporting the SARS-CoV-2 testing. What was the role of public health overall during the pandemic, and what are some of the lasting impacts on public health departments because of the pandemic?
That's excellent questions. I think that COVID has to be seen as a public health emergency, a deviation from normal. It was a pandemic. It was a new disease killing large numbers of people. And so we had to implement our continuity of operations plans. And what that means is that a lot of our ongoing basic services were not provided during the pandemic. The vital programs serving individual families in need, those were continued, right? So we continued our WIC program. We continued our home visiting nursing programs. But we stopped doing community education for chronic disease prevention. We stopped doing a lot of the things that we would normally do because we couldn't justify focusing on those issues in the middle of an emergency. And there were two reasons for that. One, everybody's attention was diverted to COVID. During COVID, if I'm talking to you about better nutrition or stop smoking, you're going to totally ignore me. I mean, you're worried about COVID and surviving this new disease. You're not going to be focusing on other sorts of issues that are not urgent to you at that moment. And the other is between the genuine demands of the pandemic and the political demands of the pandemic, we had to redirect almost all of our personnel to dealing with the pandemic. So we just didn't have humans to do the other programs. Because we had to do so much around COVID based on the mandates, et cetera. If you're asking what are the impacts of that, the lasting impacts, I think, unfortunately, are negative. One of the most important impacts, it's subtle but real, is a reduction in the workforce available to public health. We have seen between the effects of the disease on people's lives and the ability of people to modify how they work, mostly remote work in those sectors where that's possible, we're finding that younger people who would otherwise be entering our workforce are not interested in the kinds of jobs that we offer. They're not interested in the nature of the work. They're not interested in the effect of that work on their work-life balance. And so we are actually finding ourselves up against it in finding workers for many areas in human services, health services. And then the other major impact is a reduction in our credibility as public health and a reduction in trust of public health officials. And we did that to ourselves. And when I say we, I'm not blaming any one person, but over the multiple years of the pandemic, the messaging was convoluted, confused, constantly changing, and it was very unclear. And it's not surprising that people found it hard to track with what they should do. Within public health itself, there were contradictory messages being given simultaneously. And you viewed the pandemic with very different lens if you are in one jurisdiction versus another. And all you had to do was compare yourself to neighbors to see that. And so, I think that there has been an erosion in the trust of science, expertise, and data generally in our communities. And I think public health is a victim of that based on how we handled the COVID pandemic. So it's going to take a while for us to regain that. But I would say that is going to be a significant impact on our ability to be successful for a while. Now, the good news is that people equate public health with COVID. So the area in which they're going to not trust us is when we give pronouncements on communicable diseases. They don't realize that we also do these hundreds of other programs, which did not come, these were not under anybody's microscope during the pandemic. And we can continue to provide those services, and people have no clue it's public health providing it, so there's no problem. So in a way, the lack of knowledge of who we are, the lack of coherent knowledge of who we are is helpful in the sense that we can keep providing WIC programs and MCAH programs and nutrition services programs, and they don't realize it's the same buffoons who messed up on COVID.
There's always a silver lining.
Yeah.
What could have been done differently, do you think, to prevent some of those downsides?
Well, so here, I've been at this for 35 years. I've been through a half a dozen major pandemics. And I've also been trained and have been a trainer in emergency response, risk communication, risk management. And the primary directive whenever there's an emergency is to get politics out of the way and let the experts run the show. And that has never happened. Politicians are incapable of getting out of the way, absolutely incapable. In California, we essentially had an autocratic response by the governor. The governor is not a physician, not an epidemiologist, knows nothing about how to respond to a pandemic. And the secretary of HNSS, similarly, not an expert in any of these areas, yet all dictates came from them. So politicians didn't get out of the way. They didn't let us do what we thought was right. I think it's important to remember that the correct response to COVID would have varied from community to community. There is no one size fits all because our communities are so different. The transmission dynamics of this disease were very different in New York City versus rural Oklahoma. And the same strategies would not have worked. And so the problem was that we basically were not permitted to run the response as experts and had to do the best we could under the constraints imposed by politicians. So my answer is, I don't think that'll ever change. I don't think human nature will change. I don't think politicians will ever learn to get out of the way of themselves in a disaster. They want to be front and center. They want to use that to increase their own visibility. And that's not a negative statement. That's just human nature. And, this is not unusual. This is just the way humans react in an emergency situation. And there are examples of where that has been highly beneficial, right? I mean, most of us still think back to 9/11 and what Rudy Giuliani did as the mayor. And it's like, wow, that was really an extremely good response by the leader of that community to a horrible disaster. So, it's like Pavlov. Intermittent positive feedback is the worst thing possible. You get one good political response to an emergency, and now every politician wants to be in charge. So I don't mean to be negative about politicians. They play an exceptionally important role in our communities. But the answer to your question is if non-experts are in charge, you will not have a good response. So what could have been done differently is to have had experts actually do the response. But that's not ever going to happen. So in a way, my reaction is we didn't learn anything from this pandemic that we can use in the future, and we never do from any pandemic. We'd like to think we do. But the world keeps changing, right? The most recent pandemic of note prior to COVID was the H1N1 in 2009. There's only 11 years between that one and COVID. But in those 11 years, social media emerged. And our world changed so dramatically that the transmission of thought and knowledge in the pandemic with COVID was completely different from the H1N1 outbreak. In H1N1, there was respect accorded to professionals giving advice. That did not exist in the COVID pandemic because everybody's got their echo chambers, their own communication with their own friends and the people they trust. And it's all about supporting your narrative, not supporting truth. And there's nothing wrong with that. That's just the evolution of our culture. So the next pandemic is going to see a very different world than this pandemic did. So how can you translate beneficial information from this one to that without knowing what those changes will be? It's a philosophical response to your question, and I apologize if
No.
That's okay. That's just
Uh,
fine. Well, then I guess I might anticipate the answer to the next question, which is, are we better prepared for the next pandemic?
I would say not really. No, not really. And you know what? That's not a bad thing. We learn as we go. Humans, at least Americans, are not planners. We're reactors. And that is our greatest strength. When faced with something difficult, we rise to the occasion. I mean, that's what we've always done in this country, and we do it exceptionally well. What we do really poorly is plan. And, planning is hard. You have to think about all the possibilities. You have to use resources to be ready that are, in fact, not going to be used most of the time. And so, it's hard not to see that as government waste. So I think that just generically, we're better at reacting than we are at planning, which is unfortunate from a public health standpoint, right? Because we're the opposite of that. But the thing is, we do have infrastructures in place that permit us to respond well. I mean, look what happened in the pandemic. We developed testing within a couple of months. We distributed that testing in early 2020 for a disease that was just identified in 2020. And we had a vaccine within a year. I mean, the pace with which we were able to actually develop the tools that were critically important was tremendous. And so I think that unless we had forecasted that this disease would exist and had prepared a vaccine in advance of its existence, there was no faster way to respond than we did. So, I think all things considered, we responded well. And I think that that's probably what we will do in the next pandemic, is that we will face the reality of that situation and find the right solutions, and hopefully with minimum harm done.
That's a terrific lead into our next topic. We've heard that public health labs are now better equipped than prior to the pandemic, including new capabilities in molecular testing and next generation sequencing. How have the testing services offered by public health laboratories changed, and what types of diagnostic and surveillance tests are now being offered? For example, we understand that historically public health departments have been responsible for water quality in their local communities, but now also many public health departments are responsible for wastewater testing. What are other examples of changes due to this new equipment?
So, at the risk of sounding a little bit cynical, I would say that what has happened is we've developed more and cooler toys overall. But that by itself has not made our ability to do surveillance better. So we've got genomic sequencing, and we're now relying on that for everything, but we're not growing isolates in culture. So we don't really know their resistance patterns unless their resistance pattern is defined by their DNA or RNA. Well, that's not true for most resistance. And we have no way of linking cases to one another when all you have is the genome, and you don't have other serologic, for example, data to indicate the nature of that salmonella or that E. coli. And so what has happened is we have moved away from tests that require a lot of labor to tests that are more automated. We have also seen a significant migration of public health testing that is individual focused into the commercial sector and away from the public health sector. So we need to rely on them to provide us with those data so that we can track those things, but that's hard to do. So yeah, you walk into a lab today and you'd be wowed by the instrumentation and what it can do. But if you step back and say, how does this actually help in disease tracking? You realize it's actually not better, it's worse. I can no longer identify outbreaks of E. coli. It used to be that I could do that. I could find the consumer product that was offending and we could get it out of the consumer stream. Can't do that. We're not getting isolates. So we can't do the comparisons of the isolates. And in addition, a lot of the testing for other public health diseases of importance, like chlamydia, syphilis, gonorrhea, is being done in clinical laboratories. And those are not giving us the isolates, they're just giving us the result. And so again, we can't look for commonalities. And so outbreak detection has actually suffered with some of this modernization of testing. But you can also argue that that's just the direction we're going as a community. As a people, we're moving in that direction. We're less concerned about identifying outbreaks. You identify the illness in the person and you treat it, and then they move on. Is that a good thing? Is that a bad thing? That's a philosophical question. I can't really answer for everybody. For me, I think it's a bad thing because it has been helpful in my career to be able to identify outbreaks early and prevent transmission of disease. And that has actually become harder with the changes that we're talking about. But, public health is still largely responsible for surveillance of public health conditions. So, at least in those situations where there's not money to be made by a commercial lab, we're the laboratory of last resort. So, like, rabies testing is done of an animal. You're not going to get paid back by health insurance for an animal test. So public health does rabies testing. Surveillance testing for flu, just to, random testing of samples to see if this respiratory disease is influenza versus something else. You're not going to get paid back for that by health insurance. So clinicians aren't going to do that. We have to do that. So, there does remain a sector or a group of tests. And the easiest way for me to frame it is those tests that don't have a commercial benefit are the ones public health does. And that includes things like water testing. We've been doing drinking water testing and beach water testing for a very long time because that's not, you're not going no health insurance is going to pay for that. But we need to know, is the water clean? Is the water safe? And then the most recent advent is wastewater testing. And that's a really cool toy looking for a purpose. People will say, oh, if we do wastewater testing, we'll find out early or earlier that there's, say, COVID there. And my response is, so what? There's COVID there all the time. Does it matter that you found it in wastewater? No. What matters is the COVID that is transmitting in my community resulting in people ending up in the hospital? Well, I'm testing them anyway. I don't need wastewater to tell me if they're showing up with COVID in the hospital. The test at the hospital will tell me that they showed up. So if there's a lot of COVID in the community and people aren't hospitalized, then why do I care? If there's COVID in the community with a strain that's hospitalizing people, wastewater won't tell me that. Hospitalization will tell me that. So again, the point I'm trying to make is we live in a time when the allure of cool drives a lot of our decisions, and we don't take the next step of deciding if that cool has value.
In the case of wastewater, does having this knowledge ahead of the hospitalization help prepare for the hospitalizations or not?
No. And it doesn't, because the hospitals are always prepared to take a patient, right? The hospitals exist to be prepared to take care of people. Mm-hmm. So if somebody shows up with a respiratory condition, they're going to test them for flu and for COVID because they want to know, because they want to treat them properly. So the wastewater knowledge does nothing to change medical practice. Medical practice is foundationally predicated on knowledge as quickly as possible. So the question then is, well, would we promote vaccination faster? Well, we've been promoting vaccination constantly and nobody cares. So could we promote vaccination and education more quickly with wastewater knowledge? Yes. Will that make a difference? Absolutely not. So it comes down to how pragmatic are you, right? If you're an ideologue, you're going to argue, yeah, sooner is always better. And yeah, one person may get vaccinated based on all that effort I did and be protected. And a pragmatist will say, yeah, that's stupid. It's stupid because you're supposed to be doing preventive education all the time and not wait for a problem. So education should not be stopping. Promotion of vaccination should not be stopping. And all of the resources on wastewater testing to get one person vaccinated, I got to tell you, there are a million things that hurt more people that money would have been better spent on. So it comes down to wisdom in the decision of how we allocate resources. And to me, this has been an opportunity for academics and private sector researchers to identify cool new toys, and they're getting a lot of money for it. They're really happy, but it's not moving public health forward. Does that make sense?
Very interesting. Very interesting perspective.
Now, I'm going to be really clear. My perspective is probably not shared by, I would even say, most public health officials. Mm-hmm. I think you have to take everything I say with a grain of salt, knowing that I approach things from a different perspective. My training is different. My experiences are different. So I look at things different. Yeah. To me, I'm always remembering I work for my community. So I am absorbing resources from my community to protect them. And I have an obligation to use those resources wisely. Now, you could say, oh, wow, what a Republican conservative ideology. No, it's just pragmatism. It's that if I want to maintain credibility, I have to maintain value. And if I ask for all these cool new toys and all these new approaches and no value accrues from that, then I've basically been uncool to my community. So, my perspective doesn't stop at, oh, it would be nice to have this information. It's what will I do with it? If I'm not going to do something useful with that information, it's not nice to have it. It's just a waste of money.
Right.
Yeah.
We have the situation with reimbursement for clinical diagnostics where you must prove clinical utility.
Yeah.
You must prove that there's value to using that test. And I don't think we have something quite like that in surveillance.
No, we don't. Not in public health generally, actually. I think public health has had the privilege for a long time of operating in isolation from fiscal reality. We get the privilege of saying more is better. Give me more data. If you give me more data, I can look at it and find things. Well, but that's not the point of your existence. You're not there to be a researcher. There is a need for public health research, but it's not the government funded public health agency that should be doing it. That's what academia is there for. That's what commercial interests are there for, because they will take that information and make sense of it. And, if I am told of a new condition, I'm going to want to implement the capacity to look for it if it is an important condition. But not every condition is important. Just because it's emergent doesn't mean it's going to hurt people in a meaningful way. So think back emotionally to pre-COVID. We have by then we have all been having respiratory illnesses every winter, 2 or 3 times every year. We'd get sick, and we wouldn't think about it. We would just say, got a cold, going to go to work because I feel like I can work with my cold. And we didn't think about the risk of transmission to others. At the same time, in nursing homes, long-term care facilities, those very same non-virulent pathogens were killing people. So it's always been the case that there are fragile individuals at greater risk than others. So we treated them differently. We focused on protection in the long-term care facility environment differently than in the community at large. Then COVID comes along, and now everything is the sky is falling. We're hearing again, oh, COVID's coming back. And I'm like, what was the last COVID fatality that you had? COVID is still there, and it has become a disease comparable in its severity to influenza. So are you willing to do for influenza all the things you're willing to do for COVID? Because if not, you're a hypocrite. And that's what I have to keep reminding my colleagues about, is that at some point you have to put things in context. And COVID started as a unique, as a new, as a highly pathogenic organism because we were immunologically ill prepared for it. But over the course of time, we have been exposed to countless emergent pathogens. And the pathway of nature has always been, I'm going to assault you with this. You survive, you survive. You don't, you don't. And if you survive, you're going to have some immunity. And then I'm going to assault you with it periodically so you can maintain your immunity. So constant low-level exposure is the most powerful way to maintain immunity. And for some reason, we've gone ahead and forgotten that in our reaction to COVID. COVID was unique for the first couple of years, but once we had the vaccine and once we had virtually everybody been exposed to it, it stops being unique and starts being a lot more like the other pathogens that as a species, we've already learned to accommodate to. Now, having said that, you don't ever want to leave people at risk of harm. So even today, we put a tremendous amount of energy into our long-term care facilities to prevent exposure to COVID, because those are the individuals at greatest risk. But an otherwise healthy person exposed to COVID is not any different than exposure to dozens of other respiratory pathogens. And why would we be treating them differently?
Bela, I'm wondering if, the current wastewater testing programs, are they really more under a lamp light, a lamp post focus or intention here? And whereas if you were to redeploy them in true surveillance, where they're not looking, they're looking for, in the community, maybe it's polio, maybe it's drug-resistant TB, but is there a way that, the installed base of capacity now for wastewater testing could be flipped and have better application for public health?
So the simple answer is yes, but we have to research it objectively, and that's not happening.
Mm-hmm.
For example, when I was back in Massachusetts, we worked with Harvard to develop what was called SAT-SCAN. It was a data-driven analysis by time and location of diseases It's a form of syndrome surveillance with the purpose of identifying the occurrence of these conditions before they manifested as people showing up in the emergency room. We did that for several years. It was a very elegant approach. And when we tested it, we found that there were orders of magnitude more false positives than true positives. True positive outbreaks were almost always missed. And it was, at the end of the day, a completely useless approach to surveillance. We learned that because we took an elegant idea with promise and we tested it. So if we were to do that with wastewater testing, we would be able to walk away with better understanding of what is its utility. Are there certain disease conditions that are worth monitoring for, right? Maybe COVID isn't worth monitoring for. Maybe it's something else. People will argue if you monitor for COVID, you can pick up new strains. My response is until they show up in the ER, who cares? Not from a timing standpoint, but from an importance standpoint. If this strain isn't going to make people sick, why are we wasting energy on it? Because it is then no different than hundreds of other pathogens we just totally ignore.
Yeah.
So it comes down to what will you do with the information? If there is a pathogen that you can look for that actually changes what you will do in advance, then I say, yeah, we should do it. But how do you know that that's true without actually testing the system? And it's not being tested. It's being accepted as valid. It's being, people are demanding to have access to it because they think that it's giving them useful information, but nobody's actually tested the value of the information.
Mm-hmm.
That makes sense?
Yeah.
It does.
So your point's not wrong. I do think that there may be utility. The issue is, how are we going to know if we don't actually formally try to understand it? We're not wrong in wanting to identify preclinical indicators of risk. We're not wrong for wanting to do that. The problem is we're not selective in where we do that. So if it's not going to matter, we're wasting time. If it matters, that's where we should do it. So an example of what would matter is testing for a risk of bioterrorism for something like anthrax. Because we know that if you're exposed to anthrax, certain things are going to follow, and they're going to evolve so quickly that a lot of harm will occur before we can help you if we wait for clinical appearance. So looking for the presence of anthrax so that we then treat all incoming respiratory infections as potentially anthrax, that has great value. But now it comes down to probabilities. What's the probability of that type of an event occurring? We have spent billions of dollars over the past 2 decades on surveillance systems for things like anthrax that have not shown any utility. Now, is that because they have no utility? Or is that because we've been lucky and not had an event that the utility would have manifested for? This goes back to how much are we willing to invest in prevention? If we're willing to invest in surveillance and prevention, there are conditions for which I believe early detection is critically important. I really do think that there are many conditions that early detection will prevent deaths, and that's important. But then there are other conditions that we already know a lot about that are ambient in our natural environment, for which it's actually not, arguably, except for high-risk individuals, it's not good to avoid exposure to those pathogens. That's why you maintain your health. Right. And we saw that this past season with RSV and flu. I mean, we had gone 3 or 4 years without those conditions in our communities, in our environments, and we were having fatalities from previously non-fatal diseases because our immune system had waned, right? Our protection had waned. And this is not trivial. The exposures to these conditions in individuals who will not die from them is actually better for them. Problem is, you don't know everybody who's going to potentially die. And so we end up going down this vicious circle of perfect enemy of good. And, I think at some point we have to just be realistic. We know that immune-compromised individuals are more prone to a bad outcome from every infectious disease. It's by definition. How could they not be? And so focusing our prevention energies, our protection energies on them has value, right? I do believe that we should make sure the elderly in our long-term care facilities are vaccinated against flu, RSV, and COVID regularly, because I believe that their immune system response will not be sufficient to protect them in the way a younger person, a healthier person's immune response will protect them. But that's altogether different from what I would recommend for school-aged children.
Right.
So I guess my point is, we search for simple answers to these kinds of questions, and in most cases, the answers are very complicated.
Yep.
So can wastewater surveillance be helpful? Yeah, I bet we can find conditions where it is, but we're not doing that. So for me right now, it's just a waste of resources.
Mm-hmm. This is common in diagnostics again, where people want to introduce new tests like the Grail early detection for cancer, right?
Yeah.
And we don't really know what that is going to do here because there are false negatives, many of them. There are many false positives, which are going to cost a lot of money. Until we have those long-term studies, we don't really know the value of having implemented such a test. But we don't do that for surveillance tests, which is very interesting.
No, we don't. And that's what I'm saying. I mean, I think you have to reality check the surveillance test just as much as you do the diagnostic test.
Yeah. Makes sense.
But, the other side of the coin is we as Americans are really good at wasting public resources. So this is just, part of it. I'm sure that the cost of wastewater testing are pocket dust compared to the resources overall that could have been spent differently.
So Bela, your responses and your thought-provoking comments around wastewater testing and the role of surveillance are very interesting. Perhaps we might contrast that for a moment with another testing or screening program that's being promoted right now by WHO and has also been supported by the Biden administration for a funding request, and that's the Hepatitis C Elimination by 2030 program. Can you talk to us a little bit about that? And is that an example of a program that perhaps would have public health benefit and a reason for pursuing and spending budget on?
Well, and again, I want to reframe. I didn't say that wastewater testing is uniformly a waste, but unstudied, and if we can't prove it has value, it's a waste.
Right.
So the contrast there is C is different. Hepatitis C now actually has a cure, which is a game changer because it means that you can eradicate it. You can identify the Hep C positive individuals, you can treat them and not have them transmit to others. And again, like with Hep B, Hep C has known outcomes that are highly problematic. High percentage of individuals develop liver problems, they develop cancer, and die as a result of their hepatitis C. Hepatitis C has an interesting history. It was a disease that was introduced into the mainstream community to a greater degree than many other diseases because of its transmission capabilities. So typically today we see transmission of hepatitis C through sexual contact or through shared needles, through blood transmission from a positive to a negative. But there was actually widespread experimentation with IV drug use in the 60s and 70s in this country. And so populations of individuals that you would not associate with drug-using behavior were actually exposed to hepatitis C in very large numbers. So we know that there are a huge number of people who might not otherwise consider themselves at risk, who are carrying this virus and may transmit it to others, may develop bad outcomes themselves. And therein lies the value of, if there's treatment, we should find those people and treat them before they have harm and before they can pass it to other people. So I do believe that there is great value. I think the challenge is that the percentage of people that are positive is low in general principles. So you're going to spend a lot of resources looking for them. And identification of risk is hard for two reasons. One, many people won't remember that they engaged in temporary drug-seeking behavior. They just, they were high. They don't even remember the event. They don't actually genuinely remember that they shared needles back in the 1970s or 80s. And they don't want to admit to the behaviors they did engage in that put them at risk. So we know the risk factors. We ask people about the risk factors, but we don't always get honest information. And eradication is lofty and unlikely. It is possible to remove it from mainstream exposure, but I don't think we can remove it from exposure in those high-risk communities that are continuing to transmit. People who are substance users, who are addicted to that substance, people who have mental health issues and and find themselves in very difficult life situations, who sell themselves for sex to be able to find money for food or drugs, etc. These are not the individuals who are going to come to us asking for identification and treatment. These are not individuals who are often easy to identify. And so I think that we will continue to see Hep C persisting in the human population indefinitely, because the nature of transmission involves groups of individuals who are not easily or willingly identified.
Yeah.
Yeah. Sobering.
Well, yes, humanity is complicated. I mean, it is a noble notion that nobody should die of something preventable. It's a notion I genuinely believe in, but it also begs reality. We are complicated creatures who make a lot of decisions for the wrong reasons. And in any given moment of your life, you're focused on that moment of your life. You're not focused on the long term. And so we engage in behaviors that put us in harm's way. And some people will argue it's worth it. The benefit of that thing that I did was worth it. Like, we all know you shouldn't eat sugar. Sugar's bad for you. It's going to increase the risk of diabetes, but we eat sugar. And, sometimes eating the sugar reduces your stress in that moment and actually reduces your risk of a heart attack. I mean, who knows? Everything is just complicated. It's not that simple.
I haven't eaten sugar in 25 years.
More power to you. And I think that's awesome that you can do that. It takes a force of will that many of us don't possess to be able to always be doing the right thing for ourselves.
Yeah. True. Absolutely.
Bela, your views, your approach to these same topics, because Mickey and I have these discussions with, developers all day long, every day, all year long, all around the world, countries all around the world. But it's always from the perspective of, well, we can do it. We can do this. And frequently, Mickey, right, it isn't what's the end impact. We do ask that question, right? But it's not always top of mind. And this is a very, very interesting way to be thinking about, next generations of technologies, where to deploy, why to deploy, what's the right timing.
Well, I mean, I think it's important to remember that there is a research, thought-focused element in our world that is supposed to be doing that. Creating new things is important. And I'm part of the world that is supposed to ask, what's the point? So, it's not that I inherently think differently than a developer. It's that my role isn't to develop. My role is to apply. I'm an application person, not a creator person. And I can be creative in how I apply things, but, I'm applying that knowledge, not creating it, or that toy, that tool, whatever. So I have the luxury of being cynical because I don't get paid for creating a new diagnostic test, right?
Mm-hmm.
But I'm supposed to think this way because I'm a gatekeeper for public expenditures and for public benefit. Yeah. And so new technology comes along that is beneficial, I'm going to promote it. I'm going to want to do as much as I can to get it out there. Something comes along that I don't think has benefit, I'm not going to really be supportive of it. Mm-hmm. And that's not because the creation of that thing wasn't a good thing to do. And who knows that the creation of that thing doesn't lead to the creation of something else downstream that is highly beneficial.
Yeah.
And let's be honest, if you live in America and you believe in the values of market economy and capitalism, there is inherent value in creating something you can sell. I mean, that is an inherent value. And yes. I'm not going to suggest that that's inappropriate. It's not my place to judge that. My role is much more narrow. My role is all that stuff that you're doing, how does it help keep my community healthy?
Yeah. Well, a great challenge for us is working with developers and making sure they understand that unless they can establish value, they're never going to get paid for it. So you're wasting your time.
Yeah, that's true.
So we help them try to understand, if you introduce this product and you change the practice of medicine as you intend, what will the value be to the key stakeholders? And if you can't articulate that, and you can't even on the back of the envelope model that to indicate that, maybe you can't get to the performances required, but if you can, it could have this impact. And if you can't do that, you're wasting your time.
But, the challenge in that is that if the developer is operating in isolation, they don't have the information to know about its utility.
That's
right. I mean, think about the people that developed wastewater testing. They were driven by the simplistic notion that early detection is good. They haven't had the misfortune of encountering me, where, my reaction is, no, it's not. It's not inherently good. Prove to me that it actually is good for that thing, because if it's not good. So part of the issue is, are developers talking to the right people in the development phase to answer that question?
And often they aren't.
Well, we live in our silos. It's difficult to always be broad-minded.
And part of that's understanding the use case as well, right? It could be perfectly appropriate to develop it as a diagnostic
Hmm.
um, tool, but not as a surveillance tool. And we run into that, all the time,
Oh,
every day, where it's a confusion or a blurring of the use case, or it starts out for one area and then migrates somewhere else because, look, there's a whole market segment. Let's just push over there. Very thought provoking.
so what is it that you need in public health that the diagnostic community can contribute that you don't have?
Well, I think the diagnostic community focuses on the individual and their health issue. What I need from them is the information that they've identified. So what I need is transmission of information on the test results, that they've been performing. I don't need to reproduce those tests in my environment. I think that if another sector can do it, great, let them. But what we need is faithful transmission of the right data to public health so that we can use that information.
We did work on that with you for a while, a few years ago. It's still quite a challenge, isn't it?
It is a challenge, and I think in Solano County we're further ahead than a lot of other places, but we're by no means perfect. It's challenging to transfer information legitimately,
Mm-hmm.
right? It's not just the mechanical aspects of transfer; it's also the compliance and regulatory and privacy aspects of transmission. It's a complicated world, rightfully so.
Yeah.
I having dealt with data in Solano County for as long as I have, I find it genuinely amusing that most people think data have value and are useful. Almost all of the data we get is messy and unuseful until it's cleaned. There's a tremendous amount of messy in the information that we collect in our world, and you don't realize that until you get down into the weeds and try to actually make sense of something. But it is intriguing that people will say, "Oh, just go ahead and share data between the hospital and public health." Well, it's not that simple. Does public health have a right of access to the data? What EMR are they using? What system am I using to absorb it? What's going to happen with the transfer of the information? What do I do if the information is inaccurate? How do I even know if it's inaccurate?
Mm-hmm.
So, we get hospital reports to us and addresses are wrong. Names are misspelled, so I can't combine the information for the same person.
Yep.
Test results don't make sense because those results don't come out of that instrument.
Mm-hmm.
There's not a correlation between the test request and the test result. That kind of stuff happens constantly.
Yeah.
And we
Yep.
go through a laborious process of cleaning it up to make sure that it's actually valid. And so the information of this idea of transmitting diagnostic data to public health, while critically important and simple in theory, is difficult to actually implement.
Yeah. Yeah, we've done so, as you well know, we've done so much work in that area in low and middle income countries, and a severe case in point is Peru, collecting surveillance data from all of their, surveillance laboratories and using none of it because for the very reasons you're talking about, the data is just not reliable.
Yeah, it's just
Yeah,
too hard to work with. Yeah, it's hard to make sense of it.
exactly.
So, to your question about the role of diagnostic and surveillance testing in public health generally, I will say that laboratory data are foundational to public health, especially in the communicable disease realm. Absent laboratory data, we don't know what we're dealing with. And it is a blend of surveillance and diagnostic data. Surveillance data are often diagnostic data not attached to a person, right? So the same flu test you use to diagnose a patient to treat them with Tamiflu it's the same flu test that I'm doing randomly, not identifying the person so that I can see if flu is in my community. So the actual tests themselves, there's a lot of overlap. But I think it's important to remember that for communicable disease surveillance, we can't do it without laboratory data. Most of the conditions of concern that are communicable are defined by laboratory tests.
Yeah. Yeah.
Yeah. So, Bela, the laboratory services structure in the United States is quite complicated, including private laboratories, reference labs, hospital labs, and clinics found in a wide variety of urban and rural healthcare settings, now emerging retail clinic labs, and even over-the-counter and home testing. How does public health and the public health laboratories fit into this infrastructure? And do you see the role of those laboratories changing in the future?
Well, the laboratory testing world is complicated. I mean, there are many sectors performing tests for multiple purposes. I would say that the role of public health has several aspects. One is, in a generic sense or a general sense, we perform testing on conditions of public health importance for which a payer-payee relationship cannot be created. In other words, if a financial recovery model exists, in all likelihood, that test is going to be done in the commercial sector. If there is no financial recovery model, in all likelihood, it'll be done in a public health lab. So examples include random testing of respiratory samples for respiratory pathogens to see where we are in the season for evolution of flu or RSV or parainfluenza, right? We track those conditions and we do it by getting samples that we test, because those samples will not get financial recovery for the provider because health insurance doesn't care that you tested the person for that. We test for animal exposures and zoonotic exposures. We test ticks, for example, for Lyme disease. We test animals for rabies. Again, health insurance isn't going to pay for those tests, but those data are critically important to public health surveillance. When a new disease like COVID emerges, the development and evolution of that test as having utility begins in a public health lab. But then if there's a commercial model, it gets transitioned to the commercial sector. So over time, we've seen a movement of a lot of public health tests into the commercial market. STDs in particular have gone there, HIV testing, Hep C testing. These are conditions that if you identify it as positive in a patient, health insurance will pay you for that, for having done that. And now COVID, right? I mean, we always knew COVID was going to go commercial because it's a per person test. It's a person specific test identifying a condition that health insurance will pay for. So sort of that underlying generic differentiator of what comes to us is it a community benefit for that information, or is it a person benefit? And by and large, if it's not a community benefit, we're probably not the ones doing it.
Is there a safety net role for public health laboratories for the uninsured or the underinsured, where it is still a personal benefit, but there isn't really another option for getting that test result?
So the answer is yes, but how it's implemented varies tremendously in different jurisdictions. So in those jurisdictions that have robust federally qualified health centers providing care, it will not go to public health, right? Yes, it's a safety net population, but the FQHC relationship with the managed care provider includes a commercial laboratory for those tests. So for example, in Solano County, we run those clinics, but we don't do those tests in-house. They go to a commercial laboratory that the managed care plan tells us to send the samples to. So yeah, the safety net role varies. There are communities, particularly rural communities, where there isn't going to be a managed care plan and there isn't going to be an alternative commercial and testing option. And yes, they will still do those STD tests. They will still do the individual tests that might otherwise be done in a commercial laboratory.
That makes sense.
And the other part of the question, the advent of home testing, that has been, we've always had home tests for certain things. The real issue isn't, is there home testing? Isn't there? It's what disease are we doing it for, and what are the implications? So as a disease becomes less severe, as COVID has migrated from highly virulent to less virulent, the information is more personal, right? I feel sick. I'm going to test for COVID. I'm going to go get some Paxlovid because I'm positive, right? And that's not a public health realm decision. That is a medical realm decision. So the home test is used to guide your decision with your healthcare provider. That's not a bad thing, right? We send people home with blood glucose tests. We send them home with hemoglobin A1C tests, with blood pressure cuffs, right? These are tests that are done in the home environment that provide value added to the protection of your health. But it's a medical realm set of decisions, not a public health realm of decisions. So I would say that home testing typically doesn't occur if the issue is a public health realm issue, because almost by definition, there's no compensation for it, right? I mean, a public health realm issue has no compensation, so it's you're not going to have a home test kit for it.
Yeah.
Now, this also reflects to some extent the distribution of health care in our country as we are evolving away from reliance on experts to this belief that we all possess expertise. And one could argue that's wicked scary, or one could argue, hey, selection, Darwin. My point is, it's not inherently right or wrong. It's a philosophical decision. The extent to which younger people are comfortable going online to try to self-diagnose, that's a call they're rightfully making. They have a right to make that call. There is no obligation that they engage the expertise of medicine in the care of themselves. And that's, on the one hand, that's cool. There's nothing wrong with that, as long as you don't believe that everybody should get optimum health care. That approach breaks down when you are self-righteous or paternalistic about, I need to make sure you're all healthy. Well, I'm not a paternalistic health officer. I'm here for you if you have questions. If it's a community issue, I'm taking over. But if it's a personal health issue, have at it. And so home testing doesn't really interfere with public health in that regard.
What about the fact that we lost all that information about people with SARS-CoV-2 infections because it was home testing and it wasn't reported?
So that begs the question of, why did we want to enumerate cases? And I will go back to an earlier question you asked: what could we have done differently with COVID? In late February, early March of 2020, in Solano County, we identified the first case of community transmission. We also had enough information about the individuals housed at Travis Air Force Base to learn that a high proportion of COVID positives were asymptomatic. I made it very clear at that time that containment is infeasible. We cannot contain COVID. All we can do is mitigate COVID. So we turned our efforts to protecting the medically fragile from COVID. And I didn't care about counting cases. Why would I count cases? That's only important if I'm trying to contain and eliminate. Not eliminatable, not containable. Who cares how many cases there are? Those people who test at home, get a result, and don't report it to me, what difference does it make? I won't care about them until they show up in a hospital. Then I care, because I want to make sure they get health care and that they're not straining the system. So not knowing the numbers, we never should have cared about the numbers. Now, having said all of that, I was overruled from the word go. California definitely took the approach of containment, right? We forced everyone to stay at home. We shut down businesses. None of that made a difference in the transmission of this disease. Now, the problem in proving that statement is confirmation bias. People filter knowledge based on their preconceptions. Those people who indicated that those approaches were necessary will never acknowledge that they weren't necessary, because they're not capable of objective thinking. Bela, me, who believes that was the wrong approach, will never acknowledge the opposite, because I too have confirmation bias, and I can't pretend that I don't. So the problem here is, it's a conflict of narratives. But the point I'm trying to make is that if you're not about containment, case ascertainment is irrelevant. What matters is the severe cases. And those you're going to find out about, whether they home tested or they didn't home test.
Very interesting.
Bela mentioned earlier that one of the important roles of public health is to respond to the needs of the local community, which suggests that there isn't a one-size-fits-all approach to designing new products or technologies or whatever for public health, if it's going to have a regional or local influence.
The utility of diagnostic testing does not have to be uniformly applicable to be beneficial.
Right.
I don't think it's necessary for a surveillance test or a diagnostic test to be adopted everywhere for that test to have genuine value. So, for example, one could argue that hepatitis C testing is more valuable in those communities with high proportions of the population having hepatitis C than it is in populations that have virtually no hepatitis C.
Mm-hmm.
And so it's okay that the adoption of a test varies by jurisdiction, because we vary by jurisdiction.
Yeah.
Diagnostic tests are about personal illness, right? Our communities are highly variable. We are not cookie cutter across the country.
Yep.
And surveillance testing is about what is in the community and what the community cares about. There are conditions the community doesn't care about, so you won't do surveillance testing for it, even though you have the capacity to do so.
Right. It makes sense. I mean, most of the time, people are concerned about whether the characteristics of the population are such that it makes economic and clinical sense to use a diagnostic. And it often means understanding the risk assessment.
Right. And so, you take a disease like valley fever. Valley fever doesn't exist throughout the country. So unless
Right.
you travel to a high risk area or live in a high risk area, who cares about testing for valley fever in a place that doesn't have it?
Right.
You know what I'm saying? So you want to
Yeah.
have robust valley fever testing in endemic areas, and you want to have enough testing for it for travelers. But you certainly don't need robust testing in parts of the country that don't have it endemic. This
Right.
is true of Lyme disease. It's true of most zoonotic diseases that have an environmental component.
Yeah.
Yeah. Yeah.
So if someone has an idea for a new surveillance test or technology that they believe could be of benefit to the public health in the United States or elsewhere, how would you advise they go about pursuing that opportunity? And are there opportunities to get grants or some other form of funding?
So, there are multiple options for pursuing this. And yes, there are at times grants for doing it. It depends on who you are and where you are. If you are interested in diagnostic test development generically as a career, then in the public sector, you could be working at CDC or NIH or some large state health department. So there are public entities that do diagnostic test research. And even in Solano County, our lab has developed diagnostic PCR tests for conditions because we found it beneficial to do so. So, the public sector is a place where you can do it if you're in the right environment. There is also the academic environment and the private sector that performs research. So if you have a great idea and you live at home by yourself and you want to do it in your garage, I'm going to say that's kind of a non-starter, right? I mean, it's diagnostic test development is not like IT application development. It requires an infrastructure that you can't just buy at the grocery store, and and so I think you have to obviously position yourself to be in the correct sector if you want to pursue this. But I would say that a lot of diagnostic test development occurs in the private sector. There are companies that sell diagnostic tests. Of course, they would be a place where you could do development. There are also academic institutions that pride themselves on the development of new technologies. Working there would allow you to have access. They are the places that get the grants. So grants for product development aren't going to go to a person without proper credentials working for the proper employer.
Right. But is there a process where they can interact with someone like yourself or other people that understand public health to make sure they're designing the right thing?
So that's an excellent question, and I think it has two answers. There's test development for issues of immediate concern, like COVID. Because it's front and center, you're going to know who's focused on doing it because it's a public health disease of great importance that's just emerged, right? So that's a scenario where it's obvious who you should go to and what you should do. And then there's test development for conditions not currently urgent, but clearly important. And that's harder because there aren't, by and large, relationships between the creators of those tests and the ultimate users of the tests. And what you would be looking for is an open-minded entity, a company that does in fact acknowledge that the end user is important in the development process, that has that relationship, that you would then work for them because they would have the infrastructure, the communication, the collaboration to make it work well. So highly individualized, to answer your question. There are lots and lots and lots of conditions for which it would be nice to have disease testing, but there is no money to be made in it, so no company is willing to invest in it, and there is no orphan testing unless NIH makes a claim for it.
Yeah. But there is money within public health to buy tests when they will make a difference. So it's not
There is,
reimbursement per se, but it's
right. No, we procure diagnostic and surveillance test platforms all the time.
right.
Absolutely. But we have to be sold on their utility.
Right.
So over the course of the COVID pandemic, for example, we changed how we did testing multiple times. And we procured multiple new platforms to be able to keep up with that new testing. We have embraced genomic testing for a lot of conditions. So we've purchased the capacity to do genome testing. So yeah, we are an end user of that technology, and we will procure technology that we think is valuable. It's not like we have an available budget for this. It's always, where can I find the money for the newest thing? And it's always an in the immediate, what do I do to convince someone to give me the money?
Mm-hmm.
So it's not like it's not that simple, but it is our bread and butter. In public health laboratories, we have to have useful technologies. So we will procure the technologies that are useful.
Right.
The respect for public health laboratories as an element of public health is not uniform. I have encountered countless colleagues who don't see its value sufficiently to provide the necessary support for it. And we've seen a lot of public health labs close over the past decade for that reason. Labs are expensive. They require an infrastructure investment. Um, and it's hard in financially difficult times to justify that if you don't inherently value it. And honestly, when have we not been in financially troubled times? Like for my whole life, we're always in financially troubled times, right? It's like
Right.
it's like one of those background themes that never wants to go away. But you have to respect the value of the lab to keep investing in it in the face of all the things we have to do with the limited money that we have.
Yeah. That makes sense.
Well, thank you, Bela. This has been a fascinating interview and discussion about the role of public health in the United States. Very much appreciate your time today.
It sure has, and we greatly appreciate your candid opinions and thinking about all this. I think our listeners are going to appreciate that a great deal.
Well, thank you very much, Rich and Mickey both. I mean, I do have to own that I may not be mainstream in my thinking. Just keep that in mind. But I very much appreciate the opportunity to have this conversation with you.
Yeah. Well, we knew that, and that's one of the reasons we were so interested in talking with you.
Thank you.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions, or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only, and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.